Hello! I did my article on the multi-axis shoulder abduction splint in acute burn rehabilitation, and this is a randomized control pilot. So, the study compared two different splints. The first one, which was traditional for axillary burns, is kind of diagrammed in the picture next to us. So you can see it's an external splint. There is a strap behind the body, which often is difficult to apply as the patient is either sedated or in an incredible amount of pain. That's typical for burn unit patients in the acute care setting. So these are heavy, uncomfortable, and very time-consuming for healthcare staff to put on and off. And the present study tests for effectiveness of the newly designed multi-axis shoulder abduction splint with easy-to-change angle, which I'll go describe on a little bit further later. And the setting is an inpatient rehabilitation center in the general hospital. And burns around shoulders are particularly problematic because, like most patients with burns to any part of the body, patients prefer to rest in a comfortable position as possible, namely the shoulder joint in an adducted and internally rotated position, which promotes general development of contractures that can result in functional disability, which in turn make it difficult to rehab the upper extremity function of patients with burns around the shoulder, which we'll deal with SOTs. So, the introduction, contractures remain the most complex complication of burn injuries. Axillary contracture development begins early on in the acute stage in intensive care burn units. So little focus on applying a splint to hold the patient's shoulder in position required to prevent development of axillary contractures have been done. So these splints are particularly difficult to adjust just given the notion of the area. Traditional splints for these contractures are thermoplastic airplane splints, and they can be time-consuming to fabricate, they're heavy, they're uncomfortable, and then gradual development of contractures can result in loss of mobility. So for us as OTs, that's a huge component we'll be dealing with for rehabilitation. And it's difficult to rehabilitate upper extremity function for patients with burns around the shoulders. You can kind of just analyze and think that burn patients are the first primary goal for the healthcare ministers, like physicians and nurses, is going to be life-altering precautions, so dehydration from the body, pain management, decreased infection. One of the last things they're thinking of primarily is the range of motion. So getting this in early on would be very beneficial. So the participants, there's 24 patients with recent burns, and we're randomized into two groups, which just basically means roulette. You pick out of an envelope. And after 2 dropouts, 11 patients were used the new splints for 4 weeks, and 13 patients were left unsplinted for the 4 weeks. So this the intervention was the newly designed multi-axis shoulder abduction splint, as diagrammed in the picture below. This is from the case study, and it just shows how the metal arm trough is next to the bed and in place of the old splint. So the main outcome is you test them at 0, 1, 2, 3, and 4 weeks for their range of motion. And just as we were taught by Dr. Bachman in class throughout the semester, this is for active abduction, flexion, and external rotation were measured according to the zero position method by placing the axis of the goniometer, basically what we did our checkoffs on. And so, let's see. Experimental setup. So the subjects were randomized into 2 groups, like I mentioned, and they were given sealed envelopes and determined split and non-splint groups. So this flow chart gives a little visual representation, and the splint group patients were fitted with multi-axis shoulder abduction splints, so their effective shoulder was abducted as close as possible and abducted to the angle of 90 degrees, which is ideal for this kind of situation. They were instructed to wear the splint at all times, including night. So this, unless they were to be removed for purposes of hygiene or medical procedures, they pretty much had this on 24/7. So the non-splint group did not receive a splint, and all participants underwent the same exercises. So this consisted of sessions of passive and active mobility and stretching for 30 minutes twice a day. Apart from splinting, the participants underwent the same medical treatments and regular burn therapy during their stay at the burn center. And as diagrammed in the picture before, the Shoulder abduction splint consists of lightweight aluminum bar, which is foldable. Connector. It can be attached and locked to the pole of the bed. Its angle can also be adjusted to fit the position of the patient. It's applied by placing the patient's upper extremity onto the tilting trough board and then stabilizing the upper extremity with 2 detachable Velcro straps. And the foldable bar is easy to use. Physicians can fold it down for range of motions. So we can also hold it down as well. So here is just a visual graph. When the splint and non-splint groups were compared in terms of angle, gender, total burn surface area, shoulder burn surface area, and shoulder burn depth index, there was no significant difference for non-splinting and splinting patients. The results, the significant improvements in the shoulder for the abducted angle compared to unsplinted patients. So the mean outcome, the range of motion was measured again at 0, 1, 2, 3, and 4 weeks. Active abduction, flexion, and external rotation were measured. And the results showed that those who used the splint had better abduction and flexion. And after 4 weeks than the non-splint groups, there were no significant differences. The two groups did not differ in terms of flexion and external rotation. So in summary, the splint groups exhibited significant improvements in the shoulder abduction angles compared to non-splint groups. And this is one of the first times that this axillary splint has been shown to improve range of motion from an article, evidence-based practice article standpoint, just given the sensitivity of the location and patients you're dealing with, which have incredible pain. There have not been many case studies on this, which the study elaborated on throughout its entity. And this new multi-axis shoulder abduction splint resulted in significant improvement in the shoulder abduction angle compared to unsplinted patients. For years, this was considered to be to help prevent axillary burns from developing contractures, and the advantages of this splint are it's easy to put on, it's recyclable because it's aluminum, and it can be stowed away. So when patients have IV drips, etc., the conventional splints limit, the typical splints limit their ability in settings, or applicability in settings, because they're kind of attached to the body and you can't do a whole lot given the strap and the splint right here. So the external splint with the aluminum onto the bed provide incredible improvements for physical barriers such as IV lines, monitors, electrodes, large dressings. The lack of assistance from sedated patients makes it difficult to put on the conventional splints. However, this is much easier. And all of these factors explain why clinicians generally delay splinting in patients until the patients begin to show effective contractures. So they usually typically don't splint until the contractures are being shown. So this alternative comes early on in the rehabilitation center and almost prevents them, which is definitely good from an OT standpoint, prevent as much as possible. And one of the main limitations of this study was there was a small number of participants and not a whole lot of comparison literature, again, just given the notion of the injury, an axillary injury. Same with burn patients. You don't come by a lot of people who are willing to do studies on those. The main author, he invented this new splint system, but didn't have any commercial or financial interest for success, so he didn't want to pursue any patents or anything. It was strictly just research, so that is a slight limitation. And the studies showed that overall the range of motion of shoulder abduction for acute burn patients definitely increased, and this can be stowed away quickly and neatly into small places. So the novel multi-axis shoulder abduction splint was designed so the shoulder can be abducted in various angles, and I think that the study was very educational just because I want to go in an acute care setting, and knowing the prevention for burn patients, they're going to have a tough recovery road as it is, and to be able to prevent contractures, to just get them back to their normal range of motion and activities of daily living is something we should definitely focus on if possible.